Dr. Davie Wong, we're delighted to have you. Thank you again for joining us and sharing your passion with us. Dr. Wong is an infectious disease specialist at the Royal Columbian Hospital and also at Eagle Ridge Hospital in Fraser Health, which is in the lower mainland area of British Columbia. He has an office in the Burnaby area with a group called the Centrio Medical Specialist and provides HIV care for patients in Surrey. He's really passionate about antimicrobial stewardship, and as you'll see, he's quite interested in looking at not only what we do in terms of antimicrobial prescribing, but why we make the decisions that we make. He's a clinical assistant professor in the Division of Infectious Diseases at UBC. And we're just so delighted to have you, Dr. Wong, to share your information today about soft tissue and skin infections. And just before I turn it over to you, I'll warn the participants we're going to have some live polling through Poll EV, so we'll put the information in the chat. I'm going to also gather your questions as we go along. We'll save the questions to the end for Dr. Wong. So please just put those in the chat. Myself and Eric, wonderful support today, will be monitoring there. And if you have technical issues, you can put that there as well. So without further ado, welcome Dr. Wong. I'll invite you to share your slides.
All right, thanks Jessica for the kind introduction, and thank you to everyone for joining this presentation today. So I'm just going to pull up my slides. So can everyone see that?
Yes.
Okay, great. So let's get started. Let's get the formality out of the way first. So I've only received a speaker's honorarium for a UBC CME event in 2019. So this presentation has not received any funding. To mitigate bias, I've provided references where applicable, and there will be 5 poll questions for you guys to participate in. So the objectives of this talk are to improve your diagnostic accuracy of SSTIs, learn the basic microbiology, and differentiate SSTIs from common mimickers. Hopefully I can help you improve your antibiotic prescribing habits after this talk so that you can feel more confident in choosing the right drug and know when it's okay not to prescribe any antibiotic. And then we'll conclude by exploring the psychological aspect of antibiotics prescribing and selection. This last point is a topic that many people don't talk about, so hopefully you will find it interesting. So we'll just start with some basics here. Cellulitis affects the deep dermis or subcutaneous tissue, commonly involving the lower extremity, likely because the legs are often the site of repeated minor trauma. It's either non-purulent or purulent, purulent meaning it's associated with pus, abscess, boil, that kind of stuff. And it's characterized by the 4 cardinal signs of inflammation. So note that the erythema is not very well demarcated. Erysipelas is a non-purulent infection of the superficial dermis, and it's also characterized by the 4 cardinal signs of inflammation. And in contrast to cellulitis, note that the erythema is much brighter red and is well demarcated. So as expected, the signs of inflammation are not limited just to infection. Many inflammatory conditions can mimic SSTIs, so these are referred to as pseudocellulitis. The most common mimicker is venous stasis, which is often misdiagnosed as bilateral leg cellulitis. Bilateral infection is quite rare, but when you see enough cases of cellulitis, you will encounter the odd bilateral cellulitis. It's just not as common as people are diagnosing it. I've also seen people label patients with chronic cellulitis, so this doesn't actually exist. They're probably referring to venous stasis. Basically, when you think about the differential diagnosis for a red hot swollen limb, just think of all the structures in that limb that can be inflamed. So like joints, blood vessels, skin, etc. So here's some more pictures. This is a comparison between SSTIs and venous stasis. So with purulent SSTI, there's an abscess or pus with surrounding cellulitis. And with non-purulent SSTI, there's no pus, obviously. So venous stasis is characterized by bilateral leg swelling. with hemosiderin staining and is generally not as bright red as SSTI, although it could get red and itchy, and we call that venous stasis dermatitis. So this is the first question for the audience. What is the most appropriate antibiotic to treat non-purulent cellulitis of a limb? So you can go to the link there to vote. So it looks like almost half of you have picked amoxicillin, clindamycin, and doxycycline, about 20% each. So the answer is B, amoxicillin. I'll explain why shortly. So let's do question 2. What is the most appropriate antimicrobial to treat purulent cellulitis of a limb? Looks like about half are voting for cephalexin, followed by trimethoprim sulfamethoxazole, or Septra, at 23%. So the answer is D, it's Septra. I'll explain why shortly. So this is from the Infectious Disease Society of America SSTI guidelines. So they divide it into non-purulent and purulent cellulitis. So on the left side is non-purulent. So for mild to moderate non-purulent infections, the drug of choice is a beta-lactam, such as penicillin or cephalosporins, to cover for beta hemolytic streptococcus. Clindamycin is an alternative for people who are intolerant or allergic to beta-lactams. And then for severe infections, such as necrotizing fasciitis, you generally will cover more broadly in case it might be polymicrobial. On the right side, for purulent infections, the main treatment is to incise and drain the abscess, followed by empiric treatment with either Septra or doxycycline for mild to moderate infections to cover for MRSA or MSSA. And for severe infections, you can use intravenous vancomycin or daptomycin. The microbiology of SSTIs is pretty simple. So for non-purulent infections, you just want to target beta hemolytic streptococci, which are implicated in the vast majority of infections, with group A strep being the most common. The MSSA is less common. Gram-negative pathogens and polymicrobial infections are rare. And then for purulent infections, you want to target Staph aureus, particularly MRSA. Beta hemolytic strep is less common. Again, gram-negative pathogens and polymicrobial infections are rare. So basically, for most infections, you really only need to worry about staph and strep. So to determine the best empiric treatment, you should use your local antibiogram if available. So every hospital should have one. And if you work in the community, you can refer to the Life Labs antibiogram, which is updated annually. So these are SSTI pathogens submitted to Life Labs in 2019. So as you can see here, the beta hemolytic strep, group A and group B strep, are universally susceptible to beta-lactams, including amoxicillin, penicillin, cephalosporins, making these agents the drug of choice. So they are also attractive because they're very safe and quite cheap. If you're allergic or intolerant to beta-lactam, clindamycin is an alternative. Don't bother using macrolides such as azithromycin or clarithromycin because of high resistance rates. And tetracyclines and Septra are not reliable for beta hemolytic strep, so avoid that. And although the susceptibility to levofloxacin is quite high at over 90%, I would strongly advise against using fluoroquinolones because they are much too broad in spectrum and carry significant risk of toxicity. Now, if you want coverage for MRSA, Septra appears to be the best choice at 92% susceptibility. Tetracycline and clindamycin are less effective at around 70%. Although linazol is reported to be 100% susceptible, I wouldn't recommend using this first line because of its high cost and toxicities. And then for MSSA, your drug of choice is cephalexin. Septra and tetracycline are good alternatives if you're beta-lactam allergic, or if you want to cover for both MSSA and MRSA. For almost all routine SSTIs, you don't really need gram-negative coverage. So just remember, it's almost always going to be Streptococcus or Staph aureus. You should consider covering for gram-negatives only in the following situations where the risk is actually higher. Just focus a little bit on the diabetic foot infection for a moment here. So if you have cellulitis and diabetes, but without an ulcer, then you just treat as a regular SSTI. So this is not considered a diabetic foot infection. So a diabetic foot infection is diabetes plus an infected ulcer. And for a mild diabetic foot infection, you really only need to target gram-positive bugs such as staph and strep. It's only when it's more severe then you should cover gram-negatives and possibly anaerobes. So there's no particular type of antibiotic that has been shown to be superior to another. However, you should still take into account your local antibiogram data to make the best choice. So just focus on the last two bullet points here. For non-purulent SSTI, there is no benefit of adding MRSA coverage, even if the rate of MRSA colonization is high, because the most likely pathogen is still beta Hemolyx streptococcus. And because gram-negative pathogens are a rare cause of SSTIs, the routine addition of gram-negative coverage is not beneficial. So just target your treatment towards gram-positive bugs such as staph and strep. Combination therapy is only required in a few scenarios, and that is for severe or polymicrobial infections, for necrotizing fasciitis or fournate gangrene, which is a polymicrobial infection of the perineum. Combination therapy is often required. So with group-based strep neck fash, clindamycin is used to shut down toxin production. And for fournate gangrene, this is polymicrobial with gram-positive, gram-negative organisms, as well as anaerobic bugs, so broad-spectrum coverage is needed. And then for non-severe polymicrobial infections, you may or may not need more than one drug to cover all suspected or confirmed pathogens. So for example, you could use amoxicillin to cover for beta Hemolyx strep, plus doxycycline for Staph aureus. Amoxiclav is fairly broad, it gets many bugs, and this avoids the use of multiple drugs. So this is a useful drug to use for animal and human bite infections. So how do you decide which drug to use when there are so many options? So I just like to look at three broad categories: the drug, the bug, and the patient. So my general rule of thumb is choose the most effective, safest, cheapest drug with the narrowest spectrum of activity. Of course, if there are other factors that are involved, they might have greater weight depending on the situation. So you have to use your best judgment when balancing these factors. So for example, if you have a patient who is quite often forgetful, they might not do well taking cephalexin 4 times a day. So you might have to change to a twice-a-day drug like cefuroxime or doxycycline, which are broader in spectrum, but at least you can ensure compliance, right? And as a final check, ask yourself, if you're the patient, would you be comfortable taking this drug? And if the answer is no, it might not be the best drug. So let's say you have 5 different drugs you could potentially use to treat a patient. So you want to choose one with the greatest benefits and fewest harms. So in this case, antibiotic A appears to be the best option, but in a different scenario, A might not be the best choice. So there is no one size fits all when it comes to selecting an antibiotic. And there's no such thing as a strong or weak antibiotic. There are only strong and weak prescriptions. So any drug when used correctly is powerful, but any drug that's used incorrectly is weak and harmful. So even if you can cure the patient with any of these drugs, the path you take to achieve a successful outcome is at least or even more important than the outcome itself, right? So you want to reach your goal in the safest and most cost-effective manner possible. So let's see what kind of antibiotics people actually use when it comes to their spectrum of activity. So in this one study, they found that up to half of patients with a regular SSTI are receiving agents that are unnecessarily broad. And in the inpatient setting, the most commonly used drug is Piptazo, and over 80% of broad spectrum antibiotics prescribed for SSTIs are considered inappropriate. And then alarmingly, 75% of vancomycin use is inappropriate when used to treat SSTIs, perhaps because risk assessment for MRSA infection is suboptimal. Right? So not infrequently, I see people put patients on vancomycin plus ceftriaxone combination for just regular SSTIs. This is way too broad. So the inappropriate use of broad spectrum agents is not just limited to SSTIs, it extends to many other infections. But bottom line is broader is not always better. So one of the greatest myths in infection management is that intravenous therapy is superior to PO. So in fact, no study has proven this to be true. And it's well known that IV treatments are used inappropriately when PO therapy could be administered. So in fact, RCT data shows that for mild to moderate SSTIs, a PO antibody is actually non-inferior to intravenous therapy. So you really should reserve IV therapy for people who fail PO therapy, who cannot tolerate PO therapy, for example, nausea, vomiting, malabsorption, or they're hospitalized for their infection. And if someone does need IV treatment, there's no optimal timing on when to switch from IV to PO, but you generally wait until there's clinical and or biochemical improvement. And if the patient's infection has resolved by the time they've completed their IV treatment, then you should not prescribe an additional course of PO antibiotic. So this transition period from IV to PO is where unnecessary extension of antibiotic duration often occurs. Okay, so here's the next question. What is the recommended antibiotic duration for uncomplicated non-purulent SSTI? So it looks like 2/3 of you are voting 5 days and then about a third voting 7 days. So it's around 5 days, okay? So it is well known that we overtreat infections, not just SSTIs, mainly because we have no idea when the patient is cured of their infection. So most patients are treated longer than necessary, often for 10 days or more. And in fact, treatment duration of more than 5 days is actually not supported by the evidence. For purulent SSTIs, the duration is either 7 or 10 days, depending on which drug you choose following incision and drainage. So I'll talk more about duration in this slide here. So take this hypothetical scenario where the optimal duration is 7 days. So obviously we prescribe a drug because we judge the benefits to outweigh the risks. So over time, as the patient reaps the benefit of the treatment, harms begin to accumulate, right? And once you've reached the optimal duration, there are no more benefits to be gained. And if you treat beyond that, you're only subjecting the patient to harms. The optimal duration is unique to each patient, and it's almost impossible to know exactly when the infection is cured. Residual inflammation, either clinically or biochemically, often lags behind microbial eradication, and the persistent symptoms does not necessarily indicate ongoing infection. And when you look at a clinical trial that compares different durations, it doesn't actually tell you what the optimal duration is. It just tells you if a specific duration is better, equal, or non-inferior to the comparator. Right, so if you take 5 days as the recommended duration for SSTI, some people might need a little bit longer, and some people might be cured with just 3 days, but then how do you know which patients can get away with just 3 days? So who would be brave enough to prescribe less than what the guideline recommends? And so this is why there's no one size fits all. So in fact, optimal duration is an illusion because we have no idea when the patient is actually cured. So one of the most difficult questions people ask is my infection gone? Well, the real answer is nobody knows for sure. There's no way to prove with certainty that the pathogen has been eradicated. And antibiotic durations are one of the most absurd things in the practice of infectious disease. So we choose durations like 3, 5, 7, 10, 14 days, or 1 week, 2 weeks, 4 weeks, 6 weeks. There's absolutely nothing scientific about these numbers. So eons ago, a Roman emperor declared that there will be 7 days in a week. I bet you we would be prescribing different durations if he decided on 8 or 9 days, right? So if a guideline suggests 10 to 14 days, are you prescribing 10 or 14 days rather than 11, 12, or 13? So if you're doing any cooking or baking and the recipe says 25 to 30 minutes, you're not going to do 25 or just 30 minutes, right? You're probably going to consider the entire range of time recommended in that recipe, right? So why don't we do the same when treating infections? So if a patient finishes 13 days of antibiotic out of a 14-day prescription, but they're feeling better, then it would be magical thinking to think that the extra 1 day will actually make a difference. It probably won't. So please don't just prescribe durations to match the number of fingers on your hand or days in a week, right? So here's the common things you should do and not do when managing SSTI. So let's focus on the left column here. So if there's an abscess, the best treatment is to drain it. Antibiotics are secondary. Narrow the antibiotic if you have a reliable culture. So a reliable culture is inflammatory fluid like pus or infected tissue. Don't forget to address risk factors because prevention of infection is far more important than treating it. So for SSTI, an ounce of prevention is truly worth a pound of cure. Remind the patient to keep the affected limb elevated to help with symptom control. Now let's look at the right side. This is what you should not do. All right, superficial skin swabs are completely useless, so don't do them. What's growing on the surface of the skin doesn't necessarily predict the pathogen located deeper in the skin. Don't routinely add MRSA coverage for non-purulent infection because the pathogen is most likely going to be beta Helix streptococcus. So even if a patient is colonized with MRSA, that does not mean you need MRSA coverage unless the clinical presentation is suggestive of MRSA infection, such as abscess or penetrating trauma. Don't routinely obtain blood cultures because the yield is low. Only about 5% are positive. And only obtain imaging if you're worried about complications such as abscess or DVT. And this last point is very important. Don't change drugs in the first 2 to 3 days unless the patient's actually getting a lot worse, because clinical and biochemical improvement can take up to 3 days to occur. So in fact, the symptoms may actually get worse before they get better initially, as the release of toxins from the dying bacteria can trigger an intense inflammatory response. And you can see here, after 24 hours of treatment, only about 40 to 50% of patients exhibit some kind of improvement, whereas after 3 days, 80 to 90% will see a positive response. So although you could follow white count and CRP, I personally don't put much faith into these inflammatory markers because SSTI is a clinical diagnosis and improvement should be determined clinically. So I find these markers add little to no value when managing SSTIs. Some people might be fooled into thinking that these markers must be normalized before stopping treatment, but that's not the case. So what about NSAIDs or steroids? There is some evidence for this. Both can accelerate the resolution of symptoms. Steroids might actually get the patient off IV antibiotic and out of hospital 1 day earlier. The side effects of NSAIDs and steroids are well known. So even if something works, that doesn't necessarily mean you have to use it, right? Especially if the benefits are negated by the risks. So I personally like to use the fewest number of drugs to treat an infection to avoid polypharmacy. And also if you're using anti-inflammatories, that might mask a more serious condition and thereby delaying the diagnosis. So many inflammatory conditions will respond to steroids or NSAIDs, and so you might misdiagnose an SSTI and then successfully but inadvertently treat a gout flare, right? So when a patient isn't responding to treatment, you might reflexively change drugs. And although that might be the correct thing to do, please consider these 4 questions before doing so. So ask yourself, do you have the wrong diagnosis? So for example, are you treating venous stasis dermatitis with antibiotics? Do you have the wrong drug? Or are you using the right drug incorrectly? And so 1 in 6 patients with cellulitis don't respond to initial treatment because the wrong drug is chosen or the right drug is dosed suboptimally. So obese patients are at high risk of treatment failure. So ensure the dosing is optimized before calling it a drug failure. If you're using cephalexin, max out the dose at 1 gram QID, assuming normal renal function. Are you covering the right pathogen? Right? So are you treating an animal bite infection with cephalexin that doesn't have optimal gram-negative or anaerobic coverage? And then finally consider if there's a complication such as an abscess that needs drainage. All right, next question. What percentage of inpatients initially diagnosed with cellulitis is incorrect after being assessed by a dermatologist? It looks like half of you are choosing 30%, and that is the correct answer. So at least 1/3 of inpatients are misdiagnosed as having cellulitis. So now what about for outpatients? So how many of those diagnoses are incorrect? So the vast majority of you, 70%, are voting 50%. So actually, based on one small study, it's at least 80%, right? So even more shocking, right? So bottom line is think twice next time before you label someone with cellulitis. And if you're the patient, how would you feel about these odds? So misdiagnosis is harmful in many ways. It affects the patient, the system, and the clinician. So the patient is harmed by inappropriate treatment and suffers a delay in getting the right diagnosis and treatment. And for the system, there's unnecessary resource expenditure that can translate into prolonged hospitalization. And for the clinician, they might lose confidence or be accused of negligence. So basically, everyone suffers when mistakes are made. So it's important not to throw antibiotics at patients just because infection is on the differential diagnosis. So here are some clues to help you decide if you're dealing with an SSTI or something non-infectious. So SSTIs are generally acute in nature, and if the patient's symptoms have been going on for weeks to months, think of something else first before calling it an infection. If the patient's main complaint is itching, then it's likely not cellulitis. Think dermatitis or eczema. Itching can occur with cellulitis as the patient's infection is resolving, but it should not be the first or dominant symptom. And if the patient has not improved after several courses of antibiotics, that should be a red flag. So don't keep giving more antibiotics. Consult with a colleague or a dermatologist for a second opinion. And if symptoms get better with leg elevation, then that suggests a vascular problem such as venous stasis, lymphedema, or PAD. And lastly, do your best not to diagnose bilateral leg cellulitis too often. Bilateral symptoms are more likely due to venous stasis or lymphedema. So the last part of this presentation focuses on the psychological aspect of antibiotic prescribing. So prescribing behaviors are very complex because they're the results of the interplay between the science, our interpretation of the science, our own cognitive biases, and our own emotions. So a lack of objectivity can lead to cognitive errors and poor decision making. So choosing an antibiotic might be more emotional than one might think. So the next time you prescribe one, ask yourself how you would justify your choice if a colleague asks you why you chose that drug. So a proper justification should be scientifically valid, not emotional. So sometimes our emotions and biases lead us to overestimate the benefits and downplay the harms of antibiotics. But when you actually look at this objectively, the harms are very real, even if we don't recognize them. So despite what the best evidence tells us, many patients receive antibiotics too broad in spectrum or for too long. So the perceived benefit of over-treating then is to maximize the chances of a cure and prevent relapse. But you can achieve cure in a safer way. And one of the biggest problems dealing with infections is that they can instill uncertainty and fear in us. So then we take comfort in the antibiotic we prescribe, often overlooking their harms. So I'm sure we've all seen prescribers put patients on antibiotics just to be safe or to err on the side of caution, right? So this is just wishful thinking. What we are actually doing is we're accepting the risk of overdiagnosis and overtreatment over the risk of underdiagnosis and undertreatment. So we should not fool ourselves into thinking that we're taking a safe and risk-free approach. We're simply exchanging one risk for another one. And so when these drugs are used incorrectly, they harm the patient, the system, and society in many ways that might not be immediately tangible. So these harms can come in the form of medication costs, C. difficile infection, drug side effects, antimicrobial resistance, disruption of the microbiome, etc. So one of the major complications of antibiotic use is disruption of the gut microbiome. So antibiotics cause dysbiosis, which means you have decreased diversity of your gut flora. Then the nastier bugs move in to replace the ones that were killed off, and they expose their antigens to local inflammatory cells, which then can trigger a local or systemic inflammation. And this can lead to a variety of diseases such as cancer, obesity, autoimmune disease, etc. So every time you take an antibiotic, you are guaranteed harm, whether you feel it or not. So let's talk about how some of these cognitive biases impact antimicrobial prescribing habits. So a cognitive bias is basically a mental shortcut or a rule of thumb to help with making decisions. It's important to recognize and overcome your own biases to improve your decision making. Now, these biases are not all bad because they help us to make personal decisions every day. They're just not assets in medicine because they lead to medical errors and poor decision making. So let's take a look at some examples. So this one's called decision fatigue. This occurs when you experience cognitive burnout from having to make so many decisions in a day. So you might be tempted to do the easiest thing and send the patient home with a prescription or a lab test just to get them out the door, instead of taking the time and effort to explain to them why a drug or a test is not necessary. So this is an interesting study of outpatient antibiotic prescriptions in primary care office. So on the y-axis here are antibiotic prescription rates. On the x-axis is time of day. The hollow squares represent conditions for which antibiotics are never needed, such as influenza and other viral respiratory tract infections. The triangle represents conditions for which antibiotics are sometimes needed, such as pneumonia, otitis media, and sinusitis. And the diamond is the average of the two groups. So in the early morning, the prescription rates are the lowest, but still quite high at over 25% for conditions that never need antibiotics. And as the day goes on, the prescription rate increases, perhaps because the clinician just wants to get the last few patients out and go for lunch. So after lunch, the prescription rate drops, but not down to the level that was seen in the early morning. And then towards the end of the day, the prescription rate increases again, maybe because you're getting tired and just want to go home. So basically, if you want a good assessment, maybe see your doc in the early morning. And if you just want antibiotics, go at the end of the day. So the commission bias is a belief that action is better than inaction. So for example, a lab test or prescription might feel like a proper intervention. Telling a patient to go home and rest is not. But remember, not every symptom or abnormal test result requires action. And this bias might actually lead you to overestimate the benefit of an intervention and downplay the harm. So ask yourself, are you treating yourself or are you treating the patient? When previous experiences bias you in favor of certain interventions, then you suffer from the availability bias. So for example, if you've had good success using ceftriaxone for non-purulent SSTIs, you might continue to use it for every patient with cellulitis, even though it's not first-line treatment. Or let's say you recently missed a diagnosis of neck fash, and you never want to make that same mistake again. So you might over-investigate or over-treat the next patient who presents with an SSTI. So try not to let the previous case bias you for the next patient. And remember, the incidence of neck fash does not change just because you saw a case an hour ago. The only thing that's changed is your awareness of it, which is sometimes confused with the true incidence of the disease. The bandwagon effect is a type of groupthink where you do or believe something simply because your colleagues do or believe the same thing. So for example, if at your hospital many patients get vancomycin for their cellulitis, you might think that's the standard of care. But even if most people are doing the same thing, it doesn't make it right. So the standard of care isn't necessarily the best evidence-based approach. And if we have bad habits, we're likely going to teach those to other people. So the next time you have trainees on rotation with you, ask yourself, are you teaching them bias or are you teaching them proper evidence? The illusory correlation is quite powerful, and it is the belief that a causal relationship exists between your intervention and an outcome simply because one occurred after the other. So when you prescribe a drug and a patient gets better on it, the patient or the prescriber might feel encouraged to use that same drug again in the future, even if it wasn't the right thing to do. So if you feel better after taking an antibiotic, do consider other possibilities. Maybe there was a placebo effect. Maybe you were benefiting from the drug's anti-inflammatory effect, or maybe you were just going to get better with time anyway. Future discounting occurs when you value the present over the future. So when referring to antibiotic prescribing, the future is the long-term negative consequence of antibiotic misuse, but sometimes those harms are overshadowed when we overestimate the potential immediate benefits of the drug, even when there are none. So for example, it might be tempting to give antibiotics to someone who comes in with a red swollen leg of unclear etiology, simply because we think of antibiotics as a quick fix with immediate rewards. The affective bias refers to how a patient or a situation makes you feel, or you might have positive or negative feelings about a particular drug. So you might try extra hard to care for a pleasant patient, but give less attention to one who opposes you all the time, right? So diagnosing and managing infections can often trigger uncomfortable feelings that we want to get rid of, such as fear, anxiety, uncertainty. So sometimes we take comfort in having a patient stay on antibiotics for longer than they need or broader spectrum than they actually need. So in a way, we're treating ourselves. Tolerance of uncertainty greatly affects our practice because we all deal with risks differently. There's the calculated risk, and then there's the perceived risk, which don't always match. So we tend to take approaches where the risks are known to us and avoid approaches where the risk is unknown. And so because SSTIs have so many mimickers, it might be difficult to estimate the risk of a bacterial infection. So then we might just inflate that risk and prescribe antibiotics anyway. Or think of it this way, let's say you have a patient with a red swollen leg, and if this is cellulitis and you give antibiotics, then there's a good chance the patient will get better. And if you don't give antibiotics, then there's a good chance the patient will get worse. So that's pretty clear in our mind. But what's the chance of something bad happening if you prescribe antibiotics when this is not an infection? So if that seems nebulous to you, then it's probably really hard to withhold antibiotics. The aggregate bias is a tendency to believe that practice guidelines or population studies do not apply to individual patients because you see your patient as unique or special and the guidelines don't apply to them. So if you're going to deviate from guidelines, then you should have at least some counter evidence to support your approach. The law of instrument is a tendency to rely too much on a familiar tool and underappreciate alternative approaches. So let's say you have a hammer and then you get paid to use it, then everything looks like a nail to you, right? And if you have easy access to antibiotics, everything looks like an infection. And if a patient develops an infection in hospital, are you more likely to prescribe intravenous treatment over PO just because you have access to IV? With loss aversion, the tendency to avoid missing or losing something is greater than the tendency to gain something. So this can result in overprescribing antibiotics to avoid missing the small possibility of a bacterial infection. So going back to the SSTI diagnosis, if up to 80% of outpatient SSTIs are wrong, then you would need to treat 5 patients to capture 1 bacterial infection. So in other words, 4 patients are harmed by antibiotics to benefit that 1 patient. So is that acceptable? So this is my last slide. To conclude, here are some take-home points. So think beta hemolytic streptococcus and sometimes MSSA for non-purulent infections. And think MRSA for purulent infections. Try not to get fooled by SSTI mimickers. And remember that SSTIs are often overdiagnosed and overtreated, so please think twice before you label someone with this diagnosis next time. When you choose a drug, be able to justify to yourself why it's the best choice or why the alternatives are worse, because the path you take to cure the patient is at least as important as the cure itself. And so hopefully after this talk, you'll be able to identify your own cognitive biases so that you can be more objective and make better decisions in the future. So that's it. Thanks for your attention.
Wonderful. Thank you very much, Dr. Wong. A lot of practice changing ideas in there, I'm sure. Much of our treatment of soft tissue and skin infections is based on the traditions, that we learned in our education and patterns of practice that we see around us, and informed by some of those biases that you've highlighted. The chat has been very busy, so if it's okay, Dr. Wong, I'd like to just fire some questions at you, and I'll give you a minute to have a sip of water, whatever you need. But just before that, I'll say, for those, if you have to leave early, you will receive an email to request that you do an evaluation. And after the evaluation is complete, we can send you a CME certificate for credits if those are needed. And please feel free to give us any feedback that you like, or check out the website, www.ti.ubc.ca, where this recording of this seminar, as well as the slides, will be posted. So Dr. Wong, are you okay for some questions?
Yeah, go ahead.
Okay, there's a whole bunch. One theme that kept coming up was around cephalosporin choice. A couple of people said that, I think John Kramer started saying that Keflex has terrible bioavailability. We should get rid of it and replace it with cephadroxil or cefprozil. There were some questions around this and some statements too, that the problem with Keflex is it's not well absorbed on a full stomach, whereas cephadroxil is. And someone was asking, what are these drugs even covered in BC, because they're not commonly used? So I wonder if you could comment on those drugs and if they have a role in cellulitis, or what you think about them.
Yeah, so I guess your go-to drug will differ depending on where you're practicing. So in the lower mainland, everybody uses cephalexin, myself, my colleagues, and it's actually very well absorbed, is 90% or so. Main problem I see with it is that it's a quite frequent dosing, 4 times a day, so people often forget the dose. Cephadroxil, I've used it quite a few times a few years ago, and it was great because it was a BID drug, and it's basically the same spectrum of activity as cephalexin. But the problem I encountered with cephadroxil is that community pharmacies, some of them didn't stock it, so then I would send the patient around on a wild goose chase and then end up delaying their treatment, so I stopped using it. And then cefprozil, being a second generation cephalosporin, is a little bit broader than what you need. The advantage is that it is BID, and I'm not sure how available it is in community pharmacy. So there's also this practical aspect when you're trying to prescribe, these drugs.
That's fair, and I don't think cefprozil is covered under any of the pharmacare plans, whereas cephadroxil and cephalexin are. There was one related question, I may be a bit too advanced, but if you happen to know the answer, Dr. Tom Perry, a member of the TI, was asking, he posted the different half-lives of the drugs, and he said that they're kind of similar, since there's no meaningful difference in the elimination kinetics. Is there really any difference? Do they have to be given any more than once a day for SSTI? I don't know if that's something that's been looked at or not.
Yeah, I don't actually know. Like in the very early days, I know they've studied cephalexin BID. I guess, as people are getting heavier, you want to make sure that you're maximizing drug exposure, but I've not actually encountered like dosing frequency in my practice or my research. Maybe one of the pharmacists can answer that.
That's fair. Maybe they can do so in the chat. There were some other questions that were relating to that. Elizabeth Leonardis asked, what are your thoughts on cephalexin BID, like 500 or 1,000 BID, as opposed to QID dosing? Is that something that you've come across?
I've actually never prescribed it that way unless there's renal impairment, but as an alternative to the QID, I've not done it. I've not seen my colleagues do it either. So I don't really have experience with that type of dosing frequency.
Fair enough. We'll move on to some sort of specific questions about, patient scenarios. There's one example. What would be the antibiotic of choice to treat a purulent infected tattoo? Would that be any different than other purulent SSTIs?
That's a very specific question. I guess it depends what the timing of the infection is related to the tattoo. If you're talking about immediately after the tattoo was put on, then I mean your most common bugs are going to be staph and strep, right? MRSA with purulent. And then depending on the hygiene practices and cleanliness of the tattoo parlor, I mean, there potentially could be other bugs like gram-negatives. So if it's fairly mild to moderate, I would just still cover for your regular gram-positive. But if the patient is quite sick, you would not be faulted for, covering a little bit more broadly.
There was another question about antibiotic choice in people who have true penicillin allergy. So this would be for an outpatient with non-purulent cellulitis. They've got the true allergy. The BC Life Labs antibiograms say that Clinda and Septra and Doxy are not reliable options. So what would you typically do for a patient like that?
I could give a whole 1 hour talk on penicillin allergy.
This is true, the rare true penicillin allergy.
So if you judge that this pen allergy is actually real, it's still safe to give cephalosporins. There is a cephalosporin penicillin cross-reactivity table. If you guys have the Spectrum app, you can look that up and it'll tell you if there's any risk of cross-reactivity with things like cephalosporins and penicillins. But generally speaking, if someone does have a true pen allergy, oftentimes it's fairly mild, like a rash or something like that. So you could safely prescribe cephalosporins as long as you've documented and obtained a proper allergy history. I mean, oftentimes you can just delabel a patient just by taking a proper history. And if someone's actually very allergic to beta lactams as a whole class, which is quite rare, then you're kind of stuck with clindamycin, even though it's not the best choice. The alternative would be linezolid, which would have almost 100% susceptibility with streptococcus, but again, there's cost and toxicity. So that's why it's extremely important to actually get a proper allergy history before you prescribe alternatives, because we know that people with pen allergies do worse when it comes to infection management because they are getting drugs that are potentially less effective and more toxic.
Fair enough. And yeah, there's some chatter endorsing that in the chat. A lot of people, they think they have a penicillin allergy. It's just something they were told, when you were a baby, you had a rash, which we often know is totally not related to the drugs that they're receiving. More questions here. Some of them are maybe more challenging than others. And I think some of these come from the emergency physicians and nurses in the room, perhaps. This is one about the use of intravenous cefazolin with probenecid. And they're wondering, can you comment on the idea of that once daily IV therapy with probenecid? Is that effective? Are there any risks to that? Is that a good practice?
Yeah, we actually use that all the time in OPAT, and it does make things easier for the patient, that's once a day. So the probenecid prolongs the half-life of the cefazolin. So it's almost like giving it twice a day with normal renal function. And it has been studied for SSTIs, comparing that to ceftriaxone or that to oral cephalexin, and it does work. And it obviates the need to use something broader like ceftriaxone. The only concern is if they have CKD, you might not want to use it because the CKD basically serves as, a probenecid to prolong the half-life of cefazolin. And if they have any history of gout or acute gout flare, because as you're, changing the uric acid level, that make the gout flare worse. And also people tend to have a little bit more nausea, GI symptoms with it, but it's fairly minor. So we'd use it all the time and it does work.
Fair enough. Maybe just time for a couple of philosophical questions before we fully wrap up. One of the participants said, you showed a graph about overprescribing of antibiotics, which we all know happens, but how do you change the habits of those who give antibiotics too freely, and they create less trust in us who do try to give the appropriate therapy and perhaps fewer antibiotics?
Yeah, I don't think I have an answer to that question. So, you know, there is no one simple solution, right? So everybody has to be focusing on the same goal. If our goals are different, then, you know, there's always going to be misuse of these drugs and resistance. You know, so unless you somehow bring forth a system where, you know, you're discouraged from abusing these drugs, but so far that doesn't exist, right? We always encourage people to do the right thing, but if the wrong thing is done, there's often no consequences. So
that's fair. Yeah, tough tough questions. There are lots of questions about sort of misdiagnosis. Why is there so much misdiagnosis in outpatients? Is there anything that can be done to give a more accurate diagnosis in patients that other than what you've already mentioned today?
yeah, so that was a very small study, 80% being misdiagnosed, and might be very different where you're practicing. You might be a lot better than that 80%. So, but we do know that it is often misdiagnosed. And reasons are that there's so many things that can mimic it. And, you know, relating back to a lot of these biases I talked about, sometimes we just want to call it an infection so that we can prescribe something, right? It's not satisfying to say, I don't know, right? Then there's no treatment for it. And sometimes we just see antibiotics as a quick fix, or they think it's, you know, not harmful. Just give a trial of 5 days or 7 days, see what happens. So there's also the attitude towards the use of these drugs, you know, your own biases. And, you know, many people don't learn how to diagnose skin and soft tissue infections from the right people, right? So if you consider the dermatologist your gold standard, how many people do a dermatology rotation to learn how to diagnose an SSTI? Most of us don't, right? So we learn from our peers. And if our peers are teaching us the wrong thing, then we just perpetuate a culture where misdiagnosis is the norm.
It's very challenging, and yeah, especially in resource poor settings or rural settings, we don't have access to any, any of the technologies that sometimes help diagnose the other things that masquerade can be challenging. I wish we had more time to get to all the questions and statements, all kinds of interesting stuff in the chat. But I thank you very much for your time today, Dr. Wong, and your passion for making sure that our patients get the right amount of care, the most appropriate care. For those in the audience, we will be sending out emails to remind you to do the evaluations. We'd love your feedback on how we can improve and what worked well and what didn't work so well today, and ideas for future topics. And you'll receive a CME certificate by email after that's completed. Lots of kudos in the chat. Thank you again so much, Dr. Wong. It's been really a pleasure to hear from you today.
All right, thank you for this opportunity.